Good morning, everyone. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about the normal and the abnormal puerperium. So what we wanted to discuss today, the definition of normal puerperium, physiological changes, and the management. And what about the abnormal puerperium? What we wanted to know, the postpartum hemorrhage, the puerperal fever and sepsis due to either endometritis or mastitis or wound infection or urinary tract infections, septic pelvic thrombophlebitis, endocrine disorder like hypothyroidism, psychiatric disorders, and lastly uterine subinvolution. Let us start with the definition of puerperium. Puerperium is the 6 weeks following delivery. It's called puerperium, during which pregnancy-induced maternal, anatomical, and physiological changes return to the non-pregnant state. Okay, so it is the 6 weeks following delivery. And all anatomical and physiological changes which occurred during pregnancy regressing during this period. Okay, and also you should know that puerperium can be divided into immediate if within 24 hours from childbirth, yearly if within the 7 days from childbirth, remote more than 7 days and up to 6 weeks postpartum. What are the physiological changes? As regard the pulse, temperature, and after pains, the pulse is normal, but may rise if there is hemorrhage or infection. Both of them increase the pulse rate. Slight rise may occur at the 3rd day due to engorgement of the breasts. What about temperature? Usually there is normal temperature, but sometimes there is slight reactionary rise of temperature occurring in the first 24 hours and drop to normal within 12 hours. This is due to systemic absorption of metabolites due to muscle contractions. Also, there could be temperature rise by ½ degree centigrade on the 3rd day with breast engorgement. We know that the breast becomes engorgement with milk and ready for lactation at the 3rd day. There may be mild elevation in temperature, ½ degree. What about after pains? What is after pains? This is the painful uterine contraction occurring early in puerperium and increase with suckling. Why? Because there is release of oxytocin from the posterior pituitary, and this oxytocin released with reflex stimulation from suckling by the baby, and this oxytocin causes uterine contraction. And it was noticed that it occurs more with multipara. The uterus contracts vigorously at intervals and manifests as after pains, which are almost like labor pains. While in the primipara, the uterus is tonically contracted all the time, no these bouts of after pains present. But in multipara, these bouts of after pains usually occurs. What about the weight? There is loss of weight, of course, expected due to evacuation of the uterine contents and more fluid loss in urine and the sweat. About the bowel system, there is tendency to constipation due to atony of the intestine, laxity of the abdomen and the perineum, loss of fluids, and anorexia. What about urinary system? There is diuresis by the 2nd and the 4th day, lasting for 4 days. Retention of urine may occur, yes, sometimes, and be careful about this. And this due to laxity of the abdomen and the attenuation of the bladder, and long recumbency and reflex inhibition of the perineum. If reflex inhibition due to the perineal tear, which is sutured, may cause retention of urine. Also, it may be due to mechanical compression of the urethra by the vulvar edema or hematoma. Menstruation is regained by the 6th to 8th week after delivery, but in lactating women, a variable period of amenorrhea may be present. So you may expect for those with regular breastfeeding, there may be lactation amenorrhea, especially during the first 6 months after delivery. Blood changes, there is increased coagulability of the blood as during pregnancy, and they continue for the first 2 weeks. What about hemoglobin? Hemoglobin concentration tend to fall in the first 3 days. So there is drop in hemoglobin and hematocrit in the first 3 days. Breasts, there is colostrum secreted from the nipple in the first 3 days, and this colostrum is rich in protein, immunoglobulin. Milk secretion at the 3rd to the 4th day, and the breast become engorged, larger, and painful. As we said before, suckling stimulate oxytocin release, which help in ejection of milk, and stimulate also prolactin secretion, which cause milk production. And we know that prolactin is secreted from the anterior pituitary, while the oxytocin is secreted from posterior pituitary. What about the uterus? The uterus involutes, decrease in size due to autolysis of excess muscle fibers, the blood vessels obliterated by thrombosis, and the decidua, except the basal layer, becomes separated. And you imagine the weight of the uterus after delivery is 1,000 grams. However, this weight is markedly decreased by the end of 6 weeks postpartum and reaching 50 grams. After delivery, the uterus at the level of the umbilicus. After 1 week, it is midway between umbilicus and symphysis pubis, and the level of the uterus is decreasing by 1 centimeter each day till become pelvic organ 6 weeks postpartum. What about the cervix? The cervix becomes closed by the end of the first week. What about ligaments? Uterine ligaments are involuted, and if subinvolution happen in uterine ligaments, this may predispose to prolapse or retroverted uterus. What about lochia? Lochia defined as genital tract discharge during puerperium. Lochia is alkaline and composed of blood, residual fragments, cervical mucus, vaginal transudate, and white disease and bacteria. There are 3 types of lochia: lochia rubra, lochia serosa, and lochia alba. Lochia rubra, red in color, consists mainly of blood and decidua and lasts 3 days. Lochia serosa, pale brownish in color due to relative decrease in RBCs and the predominance of leukocytes, and this lasts for 4 to 10 days. Lochia alba, which is white in color, consists mainly of leukocytes and the mucus and lasts from 10 to 28 days. What about the vulva? Its gapping disappear by the end of puerperium, and any edema and ecchymosis relieved gradually. Vagina may be edematous and bruised in the early postpartum period and gradually heal back to normal, and the vaginal roget appears in the third week. We know that the vaginal wall is stretched during normal labor, so vaginal roget appear again at the third week postpartum. What about perineum? The perineum regains its tone by the end of puerperium, while persistence of its laxity may predispose to prolapse. What is the management of the puerperium? According to the diet, we need diet rich in proteins, vitamins, minerals, and fluids. Care of the bowel, including prevention of constipation by giving plenty of green vegetables, sufficient fluids, fruits, and sometimes I may need to give the patient local glycerin suppository to manage constipation. Care of the bladder, you should encourage your patient to micturate frequently. If there is a retention, a catheter is applied under aseptic conditions. But if you need to catheterize the patient more than twice in the first 24 hours, you should place an indwelling catheter, Foley's catheter, for 1 to 2 days. Okay? But avoid prolonged catheterization because it may has complications. So I insert the Foley's catheter if needed for 1 to 2 days. What about pain, mood, and cognition? For pain, I can give mild analgesics like codeine, aspirin, or acetaminophen. Preferably, various combinations are given as frequently as every 4 hours during the first few days, then stop. What about postpartum blues? It's fairly common to the mother to exhibit some degree of depressed mood a few days after delivery, termed postpartum blues. This postpartum blues can be multifactorial, mostly anticipation, recognition, and reassurance works. This disorder is usually mild and self-limited to 2 to 3 days, but sometimes may last up to 10 days. If persistence or becoming more worse, call for evaluation for symptoms of major depression. Care of the breast include wash the nipple with water and soap, especially before each feed. Encourage breastfeeding. If there is painful breast, the patient should support the breast with well-fitting brassiere and should use ice packs and analgesics, which may help to relieve the pain. Women who don't wish to breastfeed should be encouraged to avoid any nipple stimulation and also avoid manual expression of milk, and sometimes we may give cabergoline to stop milk secretion from the breast. What about rest and exercise? About the rest, the woman needs adequate rest, quietness, and sleep. Why? Because of the hypersensitive state of her nervous system. And the patient really needs adequate rest. Most women stay in the hospital for 24 to 48 hours after vaginal birth. For patients with an uncomplicated post-operative course after cesarean delivery, the postpartum stay is only 2 to 4 days according to the condition. Semi-sitting position encourage drainage of lochia with 2 hours in prone position daily to encourage anteversion of the uterus. You should encourage your patient about movement in and outside the bed and breathing exercise during the puerperium to minimize the risk of deep venous thrombosis. This is very important. Pelvic floor exercise started at the third day if there is no perineal wound. How? By alternating contraction and relaxation of the pelvic floor muscles. Also encourage the patient for abdominal exercise, but later on, these exercises have the following advantage: diminish respiratory and vascular complication, minimize future prolapse and stress incontinence, and give better cosmetic appearance later on. We advise the patient for early ambulation after delivery as soon as possible because this helps avoid urinary retention and prevent peripheral venous thrombosis and the pulmonary embolism. And you should know that early ambulation is the key to faster recovery post-delivery. What about local asepsis? The room and the bed lining, the woman's skin and the clothing should be clean. Adequate use of soap and water is the first requirement. What about the care for vulva and the perineum? Can be washed with antiseptic solution, diluted one, warm water, from before backwards after each micturition and defecation, and the sterile vulval pad is applied, and they keep the area dry and clean. If there is perineal stitches, some advise to give local antibiotic for the site of the wound. Then observe your patient during hospital stay and focus on preparation of the mother for newborn care, infant feeding, including special issue involved with breastfeeding, and also the required newborn lab test. And the care should include for the mother measuring the pulse, temperature, examining breast, follow up for lochia and involution of the uterus, for the fetus, for the jaundice development, and umbilical stump, which should be clean all the time. You should counsel the patient about birth control options before she leaves the hospital, and also should give her announcement about when to start her sexual activity. The average resumption of intercourse ranges between 5 to 8 weeks after childbirth. Postpartum sexual resumption without the use of contraception is a risk for unintended and closely spaced pregnancy. So, patients should be counseled about the use of contraception before starting sexual activity to avoid unspaced and unexpected pregnancy. What is the first visit for follow-up? The time of the first visit coming after 6 weeks postpartum. What is your aim from this visit? To detect and do follow-up for complication of pregnancy or labor, to be sure of involution of the genital tract and the healing of any lacerations or episiotomy, choice of the method of contraception, and to discover any complication happened during the period. We should take history from the patient about vaginal bleeding or discharge, breast disorders, urinary or GIT symptoms, measure the vital signs, pulse, temperature, blood pressure, and examine the breasts for any engorgement, inflammation, mastitis, abdominal examination to ensure involution of the uterus, for detection of also abdominal tool. Local examination, inspect the vulva and examine the vagina and do bimanual examination. Vulva for healing of the wound, if present, gapping of the endocritis, bleeding or discharge, any stress incontinence, and the tone of pelvic floor. Vagina for vaginitis or prolapse, cervix for laceration or cervicitis or ectomy, uterus for the size, position, tenderness, consistency, and the mobility, adnexy for any salpingitis or any adnexal swelling, perineum for any perineal tear, and if repaired and healed very well or not. If not well repaired and becomes edematous and infected, you can't do anything, just medical treatment, but suturing cannot be done and it should be delayed 3 to 6 months. You can discover any zygovaginal fistula or rectovaginal fistula. Also, you can detect any prolapse or stress incontinence, and you can advise the patient to do Kegel exercise or use vaginal cones. For cervical ectomy, this is hormonal effect, and you should counsel the patient about that and will regress continuously. Also, you can diagnose retroverted uterus, and you can advise the patient to lie on her abdomen in prone position. Also can diagnose by local examination the subinvoluted uterus. What about the abnormal puerperium? Abnormal puerperium include postpartum hemorrhage, include puerperal fever and sepsis due to endometritis, mastitis, wound infection, or urinary tract infection. Also, septic pelvic thrombophlebitis, endocrine disorders like postpartum thyroiditis, postpartum Graves' disease, Sheehan syndrome, and lymphocytic hypophysitis, psychiatric disorders like postpartum blues, depression, and psychosis, and uterine subinvolution. We will discuss each point separately. We will start with the postpartum hemorrhage, which is very important and defined as excessive blood loss during or after the third stage of labor, and the average blood loss is considered 500 milli at vaginal delivery and 1000 milli at cesarean section. So if more than that is considered postpartum hemorrhage. But here the diagnosis is based on subjective observation. But objectively, postpartum hemorrhage is defined as 10% change in hematocrit between admission and postpartum, or the need for transfusion after delivery secondary to blood loss. Early postpartum hemorrhage is described as that occurring within the first 24 hours after delivery, while delayed postpartum hemorrhage occur after 24 hours and up to 6 weeks postpartum. The etiology of postpartum hemorrhage in early one due to uterine atony, retained product of conception, or uterine inversion, or rupture, or placenta creta spectrum, or lower genital tract laceration, or coagulopathy and hematoma. While the causes of late postpartum hemorrhage include retained product of conception, infection, subinvolution of the placental side, and the coagulopathy. Uterine atony and the lower genital tract laceration are the most common causes of postpartum hemorrhage. As you see in this picture, this is a well-contracted uterus, good contraction here. Here is the atonic uterus with accumulated blood inside, because the uterus cannot contract very well and expel the blood inside, so the blood is retained inside the uterus. Here is the laceration, an example for laceration of the genital tract, paravisceral laceration. What about uterine atony? The risk factor including over-distended uterus due to polyhydramnios, multiple pregnancy, or maybe due to intraamniotic infection, or prolonged labor, or multiparity, or oxytocin administration, or prolonged labor, or use of halogenated anesthesia or nitroglycerin, or use of terbutaline, which is muscle relaxant. The uterine atony, lack of closure of the spiral arteries and the venous sinuses, coupled with the increased blood flow to the pregnant uterus, causes excessive bleeding. In lower genital tract laceration, like cervical and the vaginal laceration, we have a picture here of paravisceral laceration. Why laceration happen? Due to obstetric trauma with operative vaginal delivery, like vacuum extraction or forceps delivery, or due to other causes like macrosomic baby, precipitous labor, and episiotomy. What is the incidence of postpartum hemorrhage? It differs according to is it vaginal delivery or cesarean section. For vaginal delivery, 3.9%. For cesarean section, 6.4%. But delayed postpartum hemorrhage occur in 1 to 2% of patients. Is it risky? Yes, maybe associated with morbidity and mortality. And in the United States, postpartum hemorrhage is responsible for 5% of maternal deaths. Other causes of morbidity include the need of blood transfusion or surgical intervention that may lead to future infertility. And also, we know the risk of blood transfusion, like transmission of infection and reaction and so on. How to diagnose a case of postpartum hemorrhage? From history, the antepartum or early intrapartum identification of risk factors, as I mentioned before, like over-distended uterus, allows for advanced preparation and the possible avoidance of severe sequelae. It is important to interview every patient on admission to the labor floor and request information about parity, multiple gestation, polyhydramnios, previous episode of postpartum hemorrhage, history of bleeding disorder, and desire for future fertility. It is important to note the use of prolonged oxytocin administration. This may cause exhausted uterus and atony as a complication, as well as the use of magnesium sulfate, which is muscle relaxant, during the patient labor course. By examination, examine the vital signs and the pulse, blood pressure, respiratory rate. Of course, pulse is tachycardia, blood pressure, hypotension, respiratory rate increased. There is pallor according to the blood loss. Physical examination is performed simultaneously with resuscitative measures. The exam should include bimanual examination, which may reveal retained placenta or hematoma of the perineum or pelvis, and which also allows for uterine massage. Also, the exam should include inspection of the lower genital tract for any lacerations, and also you should examine the placenta for any lost cotyledons, because retained part of the placenta may be the cause of bleeding. The onset of postpartum hemorrhage is acute, thus intervention is immediate, and the resolution generally is within minutes. There is a little rule for lab studies or imaging in the management of immediate course of this process. However, you should check patient for blood group ABO and D blood type determination, CBC or thrombin time, partial thromboplastin time, to rule out resulting anemia or coagulopathy, which may require further treatment. Of course, you should insert wide bore intravenous cannula and give saline and lactated ringer solution and oxygen delivery. Do bimanual massage, remove any blood clot inside the uterus, evacuate the bladder using catheter, and use oxytocin infusion 10 to 40 units per 1000 lactated ringer or saline. If there is a retained product of conception, you can remove it under anesthesia manually, and you may need to do also uterine curettage. We can add carboprost 0.25 milligram intramuscular if oxytocin wasn't sufficient, and you can repeat the dose. Also, you can give methyl ergonavine, which is misogyne, is given in a dose 0.2 milligram intramuscular. It causes vasoconstriction and may cause hypertension. So be careful about hypertensive patient, because this drug is contraindicated in hypertension, because it will increase the blood pressure due to vasoconstriction. If still bleeding not responsive and no vaginal or cervical laceration, of course, if there is cervical or vaginal laceration, should be repaired. But if the patient not responding and there is no laceration, you should do bimanual compression of the uterus, as in this picture, one hand in the anterior fornix and the other hand in the suprapubic, compressing the uterus between both hands can stimulate the uterine contraction in case of atonic uterus. You can use uterine packing for 24 hours and give antibiotics and catheter for the bladder. You can insert intrauterine catheter, which is simple, inexpensive, and inflate the pulp, but you should use a large pulp. To be inflated inside the uterus will compress the site of bleeding, may be effective to control the bleeding. If the previous methods failed, we can do uterine artery embolization, as you see here, through catheter, through the femoral, reaching to the uterine artery and inject the impulse. This is could be successful, maybe reaching up to 90% or more, but some complication may develop like fever, infection, and non-target embolization, which is dangerous if you inject the impulse in another vessel reaching other organ. In patient at risk of postpartum hemorrhage like those with placenta accreta spectrum or placenta previa or coagulopathy or cervical pregnancy, a catheter can be placed prophylactically. P-Lynch suture, as you see here, can be used to do compression of the uterus and to control the bleeding during cesarean section. But another way is to do like P-Lynch suture but without incision in the uterus, is called Heyman uterine compression suture, as in this picture, without incision in the uterus, as following a vaginal delivery, and you open the abdomen and do laparotomy and do Heyman uterine compression suture. The idea is to compress the uterus and to compress the sinuses which bleed at the placental bed. Two multiple square sutures, as in this picture, can control bleeding also. If the previous lines of treatment failed, you can do uterine artery ligation, as in this picture. You ligate the uterine vessel here. Also can ligate the anastomosis of ovarian and uterine here at the cornea. If failed, we can do internal iliac artery, especially the anterior division of internal iliac artery. We can do ligation for this hypogastric vessels, internal hypogastric vessel, the hypogastric artery. Okay, so this can control the bleeding up to 50% of cases. Uterine artery can control bleeding up to 80 to 95% of cases. So we'll start with uterine artery ligation. If not responding or bleeding persists, we can do hypogastric artery ligation. If failed, we should do hysterectomy for life saving. The next complication during puerperium is puerperal fever, which is defined as elevation of temperature 38 degree or more for 24 hours or more during the first 3 weeks of puerperium. Most persistent fever after childbirth are caused by genital infection, but puerperal fever has many causes like endometritis, wound infection, chest infection, mastitis, UTI, thrombophlebitis, and any other general cause of fever like viral infection. Puerperal sepsis, defined as a genital tract infection resulted from bacterial invasion during or after labor, and the positive organism may be aerobic or anaerobic, gram-positive or gram-negative like hemolytic streptococci, or gram-negative like E. coli, Proteus, or Klebsiella, or anaerobic like anaerobic streptococci, or gram-negative anaerobic like Clostridium welchii and Bacteroides. The fever developed at the second or third day may be due to endometritis. That developed at the fourth day may be due to mastitis or wound infection, while the fever developed at the seventh day may be due to thrombophlebitis. So let us see what is the endometritis, which is the primary cause of postpartum infection, very important one. And the causative agents, usually the normal vaginal flora or enteric bacteria, E. coli, Klebsiella pneumonia, and Proteus species are most frequently identified organisms, and organisms may be polymicrobial, aerobic, and anaerobic, as I mentioned before. Endometritis complicate 1 to 3% of all vaginal delivery and 5 to 15% of scheduled cesarean section, and the risk factor include cesarean delivery, prolonged rupture of membrane, prolonged labor, pre-existing infection of the lower genital tract, multiple vaginal examination, manual removal of the placenta, placement of an intrauterine catheter, twin delivery. These are risk factors for endometritis. The diagnosis by history and examination and the lab test. From history of fever, chills, lower abdominal pain, malodorous lochia, increased vaginal bleeding, anorexia, and malaise. Physical examination, there is fever, temperature 38 or more, there is tachycardia, and there is fundal tenderness on abdominal examination. Lab test, do CBC, there is leukocytosis, ESR is elevated, CRB elevated, do blood culture for detecting the organism, urine analysis, and the culture and sensitivity test of any discharge. You should treat the patient by intravenous antibiotics, like for example, you can add clindamycin with gentamicin, and you can also give vancomycin to cover Enterococcus faecalis. When to stop parenteral antibiotic? Stop it if fever subsides and the time after drop of fever exceed 24 to 48 hours. And the patient now tolerating a regular diet and ambulating without difficulty, so there is physical improvement noticed very well, so you can shift from intravenous antibiotic to complete the course with oral one. What about prophylaxis to prevent endometritis? In emergency cesarean section, use of prophylactic cefazolin, for example, reduce the rate of postpartum endometritis and wound infection. Next complication in the puerperium is wound infection, which include infection of the perineum developing at the site of episiotomy or laceration, or in the abdominal incision after cesarean birth. The diagnosis based on presence of erythema, induration, warmth, tenderness, and urine drainage from the incision site, with or without fever. Perineal infection are rare, appear on the third or fourth postpartum day, and the risk factors include infected lochia, fecal contamination of the wound, and the poor hygiene. Abdominal wound infection, usually by Staph aureus, isolated in 25% of cases. Treatment, any abscess should be drained, as you know, and you should give the broad spectrum antibiotic and do cleaning for the wound with antiseptics. What about mastitis? Mastitis is the inflammation of the mammary gland that develops in the first 3 months due to milk stasis or cracked nipples, which contributes to the influx of skin flora. So the organism enters through the cracks in the nipple, and the presence of milk stasis, which is a good media for organism due to breast engorgement. The most common organism is the Staph aureus. Risk factors include primipara, incomplete emptying of the breast, and the improper nursing technique. That's why you should counsel and learn the patient about how to do breastfeeding, how to care for the breast. The diagnosis of mastitis by history and the physical examination. By history, there is history of fever, chills, and malaise, and the pain at the breast. Physical examination, you should focus on for searching for other sources of infection. When you examine the breast, you will see the breast is swollen, warm, red, and tender. If you found tenderness and possibility of lactant mass with overlying erythema, an abscess should be considered. How to treat mastitis? Using moist heat, massage, fluids, rest, proper positioning of the infant during lactation, manual expression of milk and analgesic, give antibiotic, penicillinase-resistant penicillin, or cephalosporin, or you can use dicloxacillin or cephalexin. Erythromycin, clindamycin, and vancomycin also can be used, especially for patients resistant to penicillin or has hypersensitivity to penicillin. Resolution usually occurs 48 hours after the onset of antibiotic therapy. What about UTI? As we know that the commonest organism during UTI infection with pregnancy is E. coli. Risk factor for UTI in the puerperium: cesarean delivery, induction of labor, instrumental delivery, maternal renal disease, preeclampsia, eclampsia, epidural anesthesia, bladder catheterization, long hospital stay, and the previous history of UTI during pregnancy. The diagnosis from history by the symptoms of UTI like frequency, urgency, hematuria, dysuria. Physical examination, you will find fever, there is suprapubic tenderness due to bladder cystitis. Laboratory test, you will do urine analysis for the patient and culture and sensitivity test, and you should give antibiotic according to the culture and sensitivity test. Also do CBC. Septic pelvic thrombophlebitis is a venous inflammation with a thrombus formation in association with fever are responsive to antibiotic therapy. Bacterial infection of endometrium seeds the organism into the venous circulation, which damage the vascular endothelium and in turn result in thrombus formation. And the thrombus act as a suitable medium for proliferation of anaerobic bacteria. There is example for septic pelvic thrombophlebitis like ovarian vein thrombosis, usually following endometritis, and the patient complaining of lower abdominal pain with or without radiation to the flank, groin, or upper abdomen. Physical examination, looking for the source of infection. There is fever, tachycardia. On abdominal examination, 50 to 70 of patients with ovarian vein thrombosis have a tender, palpable, rube-like mass. Investigation, MRI and CT is diagnostic. Treatment by giving intravenous heparin daily for 7 to 10 days and give antibiotic therapy like clindamycin, gentamicin. What about endocrine disorder during puerperium? Maybe autoimmune thyroiditis, postpartum thyroiditis, Graves' disease, and secondary disorders of hypothalamic pituitary axis such as Sheehan syndrome and lymphocytic hypophysitis, in which there is pituitary enlargement and hypopituitarism. Postpartum thyroiditis is transient autoimmune disease. Destructive lymphocytic thyroiditis can occur at any time in the first postpartum year. It has two phases. Phase 1, from 1 to 4 months, there is postpartum thyrotoxicosis. Of course, TSH is lowered down, and this patient usually treated by beta blocker to control the symptoms of thyrotoxicosis. While phase 2, from 4 to 8 months postpartum with hypothyroidism, Of course, serum TSH is elevated, and you should give the patient levothyroxine to control hypothyroidism. Lymphocytic hypophysitis is a rare autoimmune disorder causing pituitary enlargement and hypopituitarism, leading to decrease in TSH and hypothyroidism. Symptoms include headache, visual field deficits, difficulty lactating, and amenorrhea. Lymphocyte hypophysitis diagnosed. It needs, of course, histopathology to be confirmed, but you can take the biopsy, so you can diagnose by imaging techniques like MRI and CT. Most cases don't require hypophysectomy, so diagnose based on history, physical, and diagnostic imaging. Identification of the disorder becomes clearer as the pituitary reverts back to its normal size and recover some of its normal function. During the acute phase of the disease, hormone replacement often is necessary. Sheehan syndrome is the result of ischemia, congestion, and infarction of the pituitary gland, resulting in panhypopituitarism caused by severe blood loss at the time of delivery. Patients have trouble lactating and develop amenorrhea, and as well as symptoms of cortisol and thyroid hormone deficiency. Treatment, of course, with hormone replacement therapy in order to maintain normal metabolism and the response to stress. So I should give the hormones deficient due to panhypothyroidism. Psychiatric disorder include postpartum blues, postpartum depression, and psychosis. Postpartum blues in 50 to 70% of patients, and this is mild and self-limited, and occurs during the first 2 weeks and resolves spontaneously. And the treatment is just support and education to the patient. Postpartum depression occurs in 10 to 15%, more prolonged, 3 to 6 months, and the treatment includes supportive care, reassurance, and serotonin reuptake inhibitor. Any prolonged episodes of depression during or after pregnancy should receive urgent attention and should take a proper treatment. Postpartum psychosis incidence 0.1 up to 0.2%, generally lasts for 2 to 3 months, need psychiatrist, of course, better prognosis than the non-puerperal psychosis. Lastly, the uterine subinvolution as a complication during puerperium. Uterine involution is defined as slowing of the process of involution or shrinking of uterus. The causes include endometritis, retained placental fragments, uterine fibroid, or pelvic infection. The clinical presentation of the patient, there is vaginal bleeding, prolonged flow of lochia, large and flabby uterus. Treatment by administration of ecbolics like oxytocin and the ergometrin, and they give also antimicrobial therapy for endometritis. You may need dilatation and decurettage to remove the placental fragments. And of course, early ambulation is important also as a prophylaxis from occurrence of uterine subinvolution. As you see in the picture, the uterus after delivery immediately at the level of the umbilicus. After 1 week, it is midway between the umbilicus and symphysis pubis, and each 1 day drop by 1 centimeter until become pelvic organ and retain to the pre-pregnancy state. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.